Anybody want to comment about the ASCEND trial or acalabrutinib in this setting? Oh,
So-
it's not.
Well, I mean, I guess we could say, so the ASCEND trial really is
thank you.
it's sort of a trial that was really done for no good science. I mean,
I was
it
about to
really-
say, because it was,
It's really was just done to get approval for acalabrutinib in the relapse. And, in my opinion, acalabrutinib has sort of already established itself. I mean, one of the questions, of course, is, now that we have Helios data, or now that we have, the Alliance and ECOG study, do we really need to do that with each novel agent? And that's really, it'd be unfortunate if we really had to make every novel agent go through exactly the same hoops each time.
Although,
I was
one-
about
one
to say,
more
the reason
thing-
why I brought it up in
Yeah.
relapse refractory
I think
was
one more
because
question,
of,
one
correct.
advantage
Yeah.
I felt that this provided us
That's like,
was the adalimumab data.
That's
And
why I
I think
brought
most of the patients who were in the control group were treated with adalimumab, and a lot of times that questions get asked, hey, what's the right next treatment? Second line treatment, is it ibrutinib or
That's why-
BTK
well, that's why I wanted
inhibitor
to
or
bring it up.
acalabrutinib, or is it a PI3
Yep.
kinase inhibitor pathway? So I think for what it's worth, even though the study wasn't designed to address that specific question, again, we have some information that it appeared to be better than a PI3 kinase containing regimen, for what it's worth. So I think that was probably a useful piece of information. I think nobody was denying the efficacy of acalabrutinib, and we expected it to be better.
So
than the
for patients
competition.
who've had chemoimmunotherapy frontline and then relapse, still BTKI over a PI3?
Yeah, I think that's.
I'm
it
not
would-
saying, I'm just
that would be my approach here.
I think
I think to remember though that, as I stated earlier, BTK inhibitor therapy is my first choice therapy for upfront patients. If I have a relapse patient who hasn't yet seen a BTK
Then
inhibitor
you're gonna
therapy,
give them a BTK,
absolutely.
yes.
And while, this study is perhaps one of the few studies that compared BTK inhibitor therapy to PI3 kinase inhibitor therapy, the drugs have very, very different long-term outcomes. And, the follow-up for BTK inhibitor therapy is far superior than it is for all the PI3 kinase inhibitors. So at this point in time, we really have no reason to actually even really feel the need to compare the two of them.
And unfortunately, I think this trial also corroborates what we have seen in the previous trial that you have done too with Idela, that is the most of the reason that the people discontinue is toxicity, right? So it's always the argument what's happened with a PI3K that can be tolerated over time in terms of how similar they may be in the future. We always discuss different pathways, but at the same time, I think what we encountered with the available PI3K delta or gamma delta is the tolerability, which really somewhat limit the durability of this response in the long run. And this is another test or another trial who really addressed that.
So intolerance to a BTKI. Now we talked about how you can go from, with some of the acalabrutinib data, you can go from possibly ibrutinib to acalabrutinib with intolerance. What about a BTKI for intolerance to a PI3 kinase inhibitor?
Oh, I think it's been shown, at least there is in retrospective data, and it's something that also really looks like the data looks very good, because again, it's one of the main reasons. However, we don't have this PI3K mostly used in the front line, so we are really talking a different kind of patients that maybe already have chemotherapy, may really get a PI3K. So maybe we know that the delay of the BTK therapy through the lines of therapies in the really long-term data also is somewhat detrimental for the effect. Maybe not much in the intolerance, but definitely in the resistance for sure.
Because, one of the things to also keep in mind with all that is certainly we do have Idela upfront data. And I do believe that what I think is going to be interesting is, because I do think PI3 kinase inhibitor therapy is inferior to BTK inhibitor therapy, but you know what, they might be infinitely easier to, let me correct that, but they are likely easier to combine with BCL2 inhibitor therapy. And if we're just asking the BTK inhibitor or the PI3 kinase inhibitor to make the BCL2 inhibitor more efficacious, those are combinations that really might be very effective. And we have duvelisib, acalabrutinib studies ongoing. We have ibrutinib and duvelisib studies going on, and we have an umbralisib venetoclax study ongoing as well. So we have these studies now that are looking at ways to sort of find, even just because it's a a less, even because our PFS might be shorter, it doesn't necessarily mean that the drug itself is not going to be excellent to combine with another agent.
So there's still a potential role for PI3 kinase inhibitors, and hopefully some of these future studies will
Absolutely.
evaluate those combinations.
And especially in these people who have cardiac issues and bleeding issues, who we might need to look for another therapy beyond the BTK inhibitor.
Now,